What is your interpretation of this patient's EKG? What is your preliminary diagnosis? This patient's preliminary diagnosis is simple pneumothorax on the right that has rapidly developed into a tension pneumothorax with possible right-sided rib fractures and a possible right-sided clavicle fracture. How did we reach this conclusion? In a tension pneumothorax, air accumulates under pressure within the thorax. As air escapes the collapsed lung through a one-way valve, air flows into the pleural space around the collapsed lung, and pressure continues to build up, with resulting pressure placed on the heart. Tension pneumothorax is a serious life-threatening emergency that must be addressed immediately. Physical exam findings with tension pneumothorax may include shortness of breath, decreased lung sounds on the affected side, hypoxia, and signs of shock such as tachycardia, hypotension, difficulty breathing. Symptoms that are commonly discussed in textbooks but not always seen in reality with tension pneumothorax are distended neck veins and a deviated trachea away from the affected side. Treatment of tension pneumothorax is needle decompression on the affected side of the chest. By allowing air to now escape to the outside, the buildup of pressure is relieved and the patient's condition should, as in this case, dramatically improve. What is your treatment plan? Your treatment plan should include immediate cervical spine immobilization and high-flow oxygen therapy. If paramedic care is available, needle decompression to the right chest, 2 large bore IVs, and an EKG. Transport to the appropriate receiving facility, preferably a trauma center, should occur as soon as possible. The entire time you are treating this chest trauma patient, you should be performing constant reevaluations. Don't forget, these patients are very high risk for decompensating quickly. Your continued thoroughness can be life-saving. Chest trauma is responsible for 25% of civilian trauma deaths in the United States. Patients with chest trauma and severe respiratory distress have a very high mortality rate. Respiratory distress in the blunt chest trauma patient may be caused by multiple rib fractures, lung contusions, myocardial contusions, injury to the great vessels, pericardial effusion, pneumothorax, tension pneumothorax, open pneumothorax, and even hemothorax. Be thorough, be efficient, and be a detective looking for all possible clues. Tip of the month. The important point to remember in the blunt chest trauma patient is to keep the patient adequately ventilated. As always, ABC should be first. The patient with a badly bruised lung or experiencing massive pain from multiple rib fractures may not be able to expand their chest adequately to maintain oxygenation. These patients will often need respiratory support in the form of bag valve mask assistance or even intubation in order to maintain adequate ventilation. A respiratory rate greater than 30 or 35 breaths per minute is usually a strong indicator that intubation may be required. All chest trauma patients should be placed on high-flow oxygen with frequent reevaluations of both respiratory and neurologic status. Pulse oximetry should be measured constantly, and frequent reevaluations should be appropriately documented. Pearl of wisdom. In a blunt trauma patient, it is important to remember to expose both the chest and the back. Significant thoracic injuries may not be seen until looking at the posterior chest or upper back.
Well, with chest trauma, one of the things I've seen EMTs and paramedics err on is not totally exposing the chest. And it's important to remember that the posterior chest is also part of the chest as well, and that's a little more difficult to examine, but many times by not examining it, you're going to miss, wounds and such that require treatment.
Two important diagnoses to be able to recognize and treat are tension pneumothorax and open pneumothorax. If you have high suspicion of tension pneumothorax, it should be treated quickly. You never want to leave a tension pneumothorax untreated, as these patients can and will die very quickly. In my opinion, it is better to overtreat a possible tension pneumothorax with a needle decompression than to have a patient die from an untreated pneumothorax.
Mark, how you feeling now?
Other than having this needle protruding from my chest, I'm feeling better.
Okay. Let me listen to you breathe again, okay?
As always, check with your medical director and your agency's policies and procedures regarding the treatment of the patient with a possible tension pneumothorax.
Still diminished on the right, but a lot better.
An open pneumothorax, although more common in penetrating chest trauma, is also potentially deadly. Quick recognition and treatment are both critical. Symptoms of an open pneumothorax may include frothy blood at the wound site, shortness of breath, and signs of shock. This wound, often known as a sucking chest wound, should be treated with a three-sided, sterile, occlusive dressing. After evaluation, the crew in this scenario places our patient on oxygen. Noticing that the patient is developing a tension pneumothorax, the lead paramedic quickly and appropriately relieves the tension in the chest with needle decompression. The patient dramatically improves.
You know if anything else hurts, Mark.
2 IVs are established and the patient is quickly prepared for transport to the local trauma center. The crew also correctly notifies the receiving hospital early in order to give them additional time to prepare for their trauma patient. What if our patient didn't have a tension pneumothorax and just had a pneumothorax, also known as a collapsed lung? A patient with a 10% pneumothorax may not have any signs or symptoms. A patient with a large pneumothorax will often have difficulty breathing, pain on the affected side, and decreased lung sounds on the affected side, but not always. Hemothorax, an accumulation of blood in the pleural space, is often associated with a collapsed lung, otherwise known as a pneumothorax. Each side of the chest can potentially fill with 3,000 cc's of blood. A serious hemothorax of 1,500 cc's is associated with a 75% mortality, and many of these patients will